I did my presentation on sexual dysfunction in women. Epidemiology. The prevalence of sexual dysfunction is higher in women than in men, according to a 1992 National Health and Social Life Survey, which included 1,410 men and 1,749 women, ages 19 to 59. In the study, it was found that sexual dysfunction was reported more so in women, 43%, than in men, 31%. Some risk factors that the study mentioned. So women who were divorced, widowed, separated, never married, or had low levels of education. And then some other factors that can increase your risk are some urinary symptoms, stress, low socioeconomic status, and history of sexual abuse. Some subjective findings. So patients may express sexual dysfunction to the provider on their own, or they may come into your office with these complaints. But a question that some providers might ask in a well women exam is, do you have any questions or concerns regarding your sexual function? If yes, then providers can ask further questions about some of the risk factors mentioned in the previous slide. And if no, then you can let them know that you're always open to providing any answers that they may need regarding their sexual function. Objective findings. So providers may give the patient a questionnaire such as the Female Sexual Function Index. A score less than 26.5 indicates that the female has sexual dysfunction. This is the example of the Female Sexual Function Index. So some of the questions that are on there: over the past 4 weeks, how often did you feel sexual desire or interest? Over the last 4 weeks, how would you rate your level or degree of sexual desire or interest? And so on and so forth. The questionnaire has 19 questions. So differential diagnosis. So within female sexual dysfunction, there's different subcategories. So it may be hypoactive sexual desire disorder, sexual arousal disorder. They may have pain with sex or vaginismus, or female orgasm disorder. Diagnostic testing. So there's no actual test that we can use to diagnose sexual dysfunction. The diagnosis should be based on a thorough sexual history, a pelvic exam to ensure normal pelvic anatomy. So any testing should be based upon the history and exam. Testing of hormone levels is not indicated for the diagnosis. So some abnormal findings that you might find on the physical exam that could be causing these symptoms of sexual dysfunction are prolapse, vaginal discharge, abnormal uterine bleeding, lesions, pelvic floor hypertonus, atrophy, genital or pelvic tenderness. And based upon those findings, then you could work them up further by doing further testing. So the plan of care, I chose to do hypoactive sexual desire disorder. So pharmacological, a non-hormonal treatment that you could prescribe for the patient is flibanserin, 100 milligrams once daily at bedtime. And this is for premenopausal patients only. Non-pharmacological treatments could be couple or sex therapy. Some education around this. I found really great information from Planned Parenthood. So it's when a patient has little to no sex drive, and it is causing the patient worry or anxiety, or it's bothersome to the patient. There's many things that can be done or that can cause these symptoms. So like anxiety, pregnancy, medical conditions, such as chronic medical conditions, and then a bunch of other things can cause this as well. So some referrals that you can provide for the patient is couple therapy and sex therapy. And then my recommendation would be to follow up in 6 to 8 weeks for an office visit to see if the medication has been effective or if they're experiencing side effects. And these are my references. Thanks.